Good morning, everyone. What day of the week is it? Happy Thursday. That tells you how my week has been. Happy Thursday of National Public Health Week. I am so overjoyed to welcome you all here for our last Leaders in Public Health of this year. It is my true honor to welcome Mr. Chris Klomp to be our last leader in public health. I have known Chris for over a decade, and we'll talk a little bit about that over the course of the next hour. He is an incredible values-based leader. I actually invited him to join a year ago when he first got appointed as director of Medicare, and his job has expanded a little bit since then, so we'll talk a bit about that. But let me do a formal intro of Chris. As you guys know, we'll do a conversation between the two of us for about 30-40 minutes. And then we'll open it up to all of you for questions. So be thinking ahead of time around what questions you have. So Mr. Chris Klomp is Director of Medicare and Deputy Administrator of the Centers for Medicare and Medicaid Services and Chief Counselor for HHS. With extensive experience in healthcare payment reform and data sharing, he built and led Collective Medical, which is how I got to know him, which really transformed the way we took care of emergency department patients, but also transformed collaborative care in general across the U.S. He's driven healthcare reform at state and federal levels, focusing on value-based care and interoperable health technology, has served as a Utah Senate-confirmed commissioner of the Utah Digital Health Services Commission, previously was vice president in Bain Capital's North American Private Equity Group and worked at Bain & Company. And I could go on with honors and accolades, but I think one of the things that I think is most awesome is that you're splitting your time between DC and Utah, living with your wife and 4 kids. And so still have very much a human aspect to your life on top of trying to change the American healthcare experience. So Chris, really welcome. Welcome to the Yale School of Public Health.
Megan, so grateful to be here. Appreciate it.
So I'm going to I often start by kind of talking about people's journeys. And you and I first met through what was then called the ED Information Exchange. And I remember having a conversation with you out in a parking lot in Rhode Island.
I remember it distinctly.
As we were trying to convince the state of Rhode Island to adopt this amazing product and failing. And I'd love for you to share with our audience a bit about how you got interested. It's part of your journey that I think people don't think about, but kind of what brought you into creating Collective Medical and going from Bain to CMT, what that journey looked like, what got you interested in kind of the care delivery side of healthcare.
Well, thanks so much for having me. I'm so grateful to get to be with a good friend. So my healthcare journey started actually much earlier. My dad's a physician, as OBGYN, specialized in gynecological microsurgery and infertility, delivered close to 10,000 babies over his career, and he's old school. He talked about being a healer was the highest calling, and he believed it. He always took his own call unless we were out of town, and I idolized him. I wanted to be just like him, and so I wanted to be a physician. I showed up at Brigham Young University, pre-declared microbiology, biochemistry. And then when I was 13, my mom died of leukemia, and that was triggered based on a cellular mutation from an experimental treatment for severe rheumatoid arthritis that was onset by my birth. And I think I carried a chip on my shoulder over that. Turns out there was medical error, and the study designers had studied this trial, but the people who were effectuating the trial had made a mistake and pretty severely overdosed her with the drugs that led to this mutation. And so I had this kind of yin-yang pull-push notion toward healthcare. I resented it. I honored it. I wanted to be part of it. And as is customary in our church, I took 2 years to serve a mission. I was assigned to serve in Eastern Europe and had a number of interactions with the Romanian healthcare system at the time that was probably about 40 years behind the U.S. state of art. And it was frustrating to see this inequity and level of suffering of things that we took for granted in the United States as easily fixable that they could not. And this church leader came to visit. I was assigned to drive them around for a week as they were visiting missionaries. And he'd been the CFO of BF Goodrich. He was my first exposure to business and management. And he introduced this concept of management to me. Took an interest in me, wanted to know what my hopes and dreams were. And said, you could become a physician, but you could also work in public health. You could learn how to manage and organize and grow organizations, and you could have impact at a different level of scale. He wasn't steering me. He was just trying to get me to think about things a little bit differently. And I'd grown up in Idaho and just hadn't had exposure to that. Didn't really know that existed, but that was eye-opening to me. And so I went to Bain, and I went to Bain Capital, and I got to learn from brilliant people around organizations and leadership and building things, but always with an eye to wanting to be in healthcare. And when I was in graduate school, I started working on a couple of businesses with dear friends, one of which was Collective, co-founded by two of my childhood best friends. And the premise was simple. One of their mothers was a social worker in the emergency department, and this is close to 30 years ago, 25 years ago, realized that a subset of patients would visit her hospital emergency department, and they looked familiar, but they had no prior history, and they'd have a different name and different information, but always a consistent diagnosis: a nondescript lower lumbar back pain, acute migraine, acute abdominal pain, something like that. And they were struggling with opioid use disorder. And we hadn't named the opioid epidemic yet as an epidemic, but she recognized them and saw what was happening and built a series of paper pencil-based workflows. And no one was thinking about the emergency department as a serial care setting. It was episodic. So, you didn't think about working with your fellow emergency physicians in different respects and different channels. And yet that became the primary care channel for a lot of patients, often the most in need, indigent circumstances, those who had no insurance or were on Medicaid. And so we needed to meet them where they were. And these were individuals, said no 5-year-old at their kindergarten graduation ever, when I grew up, I hope to be addicted to anything. And yet this happened. And so the idea was to stitch records together and help these otherwise disparate care teams act like they were on the same team with the same picture, so that we could help these patients with their underlying behavioral health challenges. And the notion of getting hospitals at this time to give us all of the clinical records and allow us to pool them together and use a lot of advanced analytics to stitch together these different names and different demographics to realize they were the same person, and then share them back with competitors, was a huge lift. It was a total non-starter, right? We talk about interoperability now, and people kind of get that it needs to be a thing, but it wasn't then. So this was a real tough row to hoe. The company totally went nowhere for the first 3 years. Everybody had to go off and get jobs. No one was going to do it. And then we started to get traction because of people like Megan, who saw this, and they were experiencing it. And they, of their own volition, without any personal gain, would go and they would advocate to states like Rhode Island. They would advocate to their hospitals and health systems, say, we need to do this. We need to invest in this. This is the right thing to do. And they would fight this fight over and over and over. And that became the largest real-time collaboration network in the country. More than half the hospitals in the country use it, all the national health plans, loads of others, hundreds of millions of Americans. So it's an incredible thing to get to build.
And I will say it was truly incredible. We were trying to figure out how to identify and help these patients, and we literally could not do it. And this program that you created and then continued to perfect gave us the tools to identify and provide real public health services to patients so that they stopped coming back to the emergency department over and over again. We used it for addiction. We used it for people that we called quote unquote frequent flyers. Right. And then some states, like the state of Rhode Island, insisted they could do it better than you without your system, and have ended up realizing that wasn't true. So I think, and I think, what is it? First of all, I love your story about service. We frequently talk here about that importance of giving back and actually being out in the community and being on the ground, and whether it is your 2 years in service, whether it was my time in the Peace Corps, the way in which that changes the way that you think about the world. I also love in your story how you talk about kind of the moral obligation. And I've heard you, I mean, you and I have talked about it, kind of the North Star, but also in a lot of public interviews, you talk about there being a moral obligation and a responsibility when you are working in health, whether on the business side or on the government side. And I'd love for you to share a little more about that, again, before we go into your government service side, about how you thought about that in running a business, how did you operationalize this idea of obligation and responsibility to the people you were hoping to help?
If you walked into the walls or the doors of, hopefully you weren't walking into walls, but if you walked into the doors, you could do that too. We'd be there to catch you. If you walked in the doors of Collective, it felt like a nonprofit. It was a for-profit enterprise. We bootstrapped the first, few tens of millions of revenue, and then eventually took venture funding. And our use cases proliferated significantly over time, well beyond the emergency department, but always for the same idea of how do we help care teams work together as a team for the good of the patient, and use data as the center of that. But it felt like a nonprofit. It was a mission orientation. I remember when we were thinking about raising capital, we had real concerns that would change the notion of what we were trying to do, because we made a lot of decisions that weren't profit optimizing. We were very comfortable with that because they were very consistent with our mission. And organizations talk a lot about a mission. I think for a lot of organizations, mission is something that you put on the wall and you talk about, but it's not orienting. But if you actually very clearly articulate a deeply thoughtful, intentional mission and vision, and as important or more importantly, the values that undergird those, then it makes it very easy to make decisions because you run all of your decisions through that framework. And if the decision doesn't check off in compliance with the mission, you already know, but more importantly, so does everybody else in the organization before the decision ever even gets to you, that it's not something you're going to do. So when we were raising money with investors, we were very intentional about highlighting different decisions we had made that were not revenue or profit maximizing, and making it very clear that if they were going to join us, we were going to continue to do that, and they needed to trust us that the way that we had focused and honoring those values and pursuit of that mission up until that point, that it caused this to be an organization in which they wanted to invest, would continue to make this a good investment for them, but it would allow us to honor the reason we started in the first place, which again was Adam, my co-founder's mom, Patty. You don't go into social work because you want to make money. I think everybody understands that. She didn't care about any of that. She cared about this mission that she wanted us to fix and solve and pursue. And so that carried forward, I think, in a lot of regard. I was inspired by people like Megan and others throughout this journey who very clearly were self-sacrificing in pursuit of something bigger than them and bigger than their pursuit of self-interest, and started to build this thesis around there are a lot of ways to make money. And frankly, there are much easier ways to make money than in healthcare. There just are. Like if you are hoping that you're going to be a budding entrepreneur to get rich, I would argue healthcare is not the space to play. Not that you can't do that, but there is a moral obligation, and it's a higher moral obligation, and we should take it seriously. And I suspect the very fact that you all are here and you've chosen to be in this domain, you understand this, or at least are beginning to understand this, which is if there's one issue that shouldn't be partisan in our country, there's one issue that shouldn't be a red, blue, left, right issue, it is health. It's health care. And we all talk about health care, and we, I think, sometimes assume in our echo chamber that the rest of the American people care about health care. They don't. People don't care about health care if they don't work in health care until the moment that they or a loved one loses their health. And then it very quickly becomes the most important thing in their world. It also happens to become the thing that they have the least amount of control over because it's so staggeringly complex. It's so administratively difficult. It's so confusing. It's a foreign language. And you have this moment of desperation where you are utterly reliant on the system and the people around you to care for you. And so if you want to participate on that team and in that system, you are signing up literally for someone's life. And that is a moral obligation. That is a calling. And if you don't want to do that, you should go work in another industry. And I'm not maligning you, but you should be invited to go do that. But if you're going to be here, you have to start with mission first. We pushed out a final rate notice in Medicare Advantage this week. The rate notice, for those who are not policy wonks, is how we pay Medicare Advantage plans. Medicare Advantage accounts for 54% of our 68 million beneficiaries right now. So this is where we have gone to private insurers and said, we're going to pay you, and then you're going to render benefits, and we're going to give you a pretty good idea of the benefits you need to render, and then we're going to hold you accountable to a bunch of different quality measures and clinical outcomes. And if you do that, you get to participate. And by and large, beneficiaries really like their Medicare Advantage plans. And Medicare Advantage, we have made very clear, is a central component of the future of Medicare. We're investing in it. There's a good reason we're investing in it. Medicare Advantage and accountable care organizations, where you have a serial, long-term relationship with your provider, yields superior clinical outcomes. Every single metric, quality metric that we track for our beneficiaries, outperforms in an accountable care relationship, a value-based arrangement, than in a fee-for-service relationship. And our mission at CMS, I'm putting my CMS hat on and my HHS hat for a second, is to unlock American potential for every American. That seems like a weird mission for like the largest payer on the planet. Why do we care about that? Because it's really hard to reach your full potential as an individual if you're sick and you don't feel well. It's hard to get out of bed and do your best work. And it's hard for us to reach our full potential as a country if our individuals can't reach theirs. So we have to set the rates for Medicare Advantage. It's a really important program, but we have observed that sometimes people are competing in Medicare Advantage on the basis of playing games with how they, what's called risk coding, how they code, how they assess beneficiaries that come onto their plan, rather than on the basis of helping those beneficiaries lead their healthiest lives and have excellent clinical outcomes. And so we passed a bunch of regs to try and tighten that up and make it clear that that is not the basis for your margin or your market share. And if that is where you want to compete, you need to get out of the program. We don't want you in. There's not a place for you. Your job is a higher calling. It is a stewardship. If you want to serve in government, if you want to serve in Medicare, and it is a service, then you have to honor the values that we're establishing, and you have to actually help people live healthier lives on a cost-adjusted basis. If you want to play these other games, don't play. So all of these things feed, and these are all lessons and I think values that have been developed over decades that we are incorporating into the work that we do that drive our policy from a principles perspective now.
I love that. And that brings me to why you chose to become Medicare director. So now I'm going to start taking us through the journey. So Bain, CMT, took a little time to try to be with your family. And then you got asked to come and join HHS. Again, we're going back a few titles to simply be director of Medicare, which, as you say, is one of the largest payers in the world. Takes care of people not just 65 plus, but people with disability, with end-stage renal disease.
That's right.
And I know you struggled with the decision of whether or not to take that job. And can you share a little bit with the folks here about kind of that process of why you did decide to take the Medicare job and what your hopes and dreams for it were? I think you just gave folks a bit of a preview, but.
Yeah, so as Megan mentioned, we have 4 young children. And in homeschool, we homeschool them. We started doing that in COVID. My wife is in education, as experiential curriculum design. And for a variety of reasons, we started homeschooling and continue to homeschool. And by we, I mean she. And she's incredible. Last year, I guess now 2 years ago, they did a unit for a year on constitutional history. Mm-hmm. And some of our youngers were maybe not as excited about that topic, and it wasn't very real, but we said, if you get through that whole thing, then we're going to go see the things that you're studying. We'll spend 30 days and do a constitutional history civics trip. And so we did. They did their work, we went, and it started 1607 Jamestown, 1620 Plymouth, all the way through about 6 years beyond the Revolutionary War, and then we jumped to modern day DC. And my wife had 3 learning lessons for this trip. Number one, that a Revolutionary War was fought over a revolutionary idea, that a government could be accountable to its people and not the other way around. We take that for granted now, but that was pretty unique then, and people were willing to die for it. Number two, that the founding fathers and mothers, albeit flawed, were divinely led and established this fledgling democracy. We wanted to understand what that meant. And number 3, that democracy is and remains fragile, and it requires people to answer the call. And so we tried to highlight people throughout history over the course of a couple hundred years who had answered the call in their local church, in their community, in the military, in government, and other ways. And the conclusion was that we said, we hope that someday you will get a call, and when you get that call, we hope you'll answer. And so on day 4 of this trip, it's a Sunday afternoon, and we're picking apples in an apple orchard in New England, and a call comes in from the president's transition team and says, hey, in the event that we win in November, would you be interested in coming in and serving in CMS? And I said, well, I had never thought about that, and what would that look like? And we talked about it. We had a nice conversation, and I hung up, and then I did not call back. I wasn't interested. We were kind of getting ready to start some other organizations, some new companies in healthcare, and I was trying to focus a little more on being present with my family. And we go through the next 26 days of highlighting people who had answered the call and trying to teach our children that they needed to answer the call. And the hypocrisy was becoming deafeningly loud. And I knew that needed to happen. And it was predicated on this notion, if nothing else, very personally, that the social contract when you become a parent is that you're going to make the world better for your children than they found it. And in healthcare, that is categorically not what has happened. We're worse than we've ever been. We have extraordinary care, and yet our clinical outcomes as a country we've never been less healthy. Mm-hmm. More than 6 in 10 Americans have chronic disease. 45% are polychronic. 43% are obese, which is equal, by the way, to smoking 20 cigarettes a day. It's a 30% increase in mortality. 74% of Americans are overweight. 21% of military age youth are actually fit to serve. These are huge issues. And by the way, for the privilege of that, we're spending $15,500 per capita per year right now on it. So we've never spent more. It's 20% of GDP. It's growing twice the rate of GDP for the privilege of being less healthy than we've ever been. So we're definitionally and objectively not leaving the world better than we found it. And I take that seriously. And it's been a privilege to get to work in healthcare now for decades. And I think there's an opportunity to take another swing and try to do more. And so it's been a privilege. And that experience and that call coming at that time on that trip was a blessing, not just for me to put things in perspective, but for my family to understand why we were going to do this thing. And maybe they weren't going to see Dad quite as much.
or hardly ever, yes.
Hardly ever. But they're bought in because they know what we're doing right now and they understand that this is a chance to answer.
That's awesome. Now, you've shared with me a bit about your entry into CMS and kind of getting to know your team and thinking about reshaping it, what your priorities were. Do you mind sharing? We talk a lot about systems thinking at the school. We talk a lot about how do you lead from the middle, from the top. And in that director of Medicare, you had a leadership role, but you're also reporting up to a lot of folks. And you have a tremendous responsibility. Can you share about kind of those first weeks, what they were like, and how you got to know the system and started to create your list of priorities?
Absolutely. So first, I'm going to brag on our career team. And I don't know, has anybody ever spent any time at CMS or HHS? Like, do you know anybody there?
We've got a few in the room. Yeah.
I hope you do. If nothing else, we should arrange a field trip and
yes.
I don't know, I'm putting you on the spot.
Yeah.
No, but like
we'll
actually.
We'll come next year, seriously.
And I hope that you do.
Sorry
get to
our
know them
graduates. We'll get to you, I promise.
We can do a bonus program.
Yes.
You can come back as alums. That'll be like your grandfathered in. Our career team of civil servants is extraordinary. These are incredibly thoughtful, incredibly gifted, incredibly skilled individuals who are unquestionably amongst the smartest people on the planet in every facet of the American healthcare system. They're totally dedicated to the program. They love the programs that they serve. They love their country. And when you ask them why they're there and why they're there making probably a fraction of what their market value would be in the private market, the answer is consistently because this is where I can make the biggest difference. It's not all the dumb reasons that you hear people throw out when they're criticizing career civil servants. Oh, they're risk averse or they're lazy and they don't want to work hard. Actually, quite to the contrary. They work exceptionally hard. They work when governments are shut down and without pay. They don't stop. They do all the things. They're hyper responsive. So that's our career team. The system that we're set up in has career teams and it has politicals. The career team is in the back and they're doing the work, and the politicals change, right? The people vote in at administration. The administration appoints people like me, and then we make the decisions based on the recommendations of the career team, which in and of itself is both a beautiful thing of democracy in action, and also you can imagine challenging for these exceptionally talented career individuals who probably already know the right answer, and they've got to put up with teaching someone like me the 101s so that they can lead the horse to water and make a good decision. But in that process, I observed a few things. Healthcare has become so stunningly complex and so large. Medicare alone is a $1.1 trillion program, so large and so complex with so many moving parts and so deeply technical. I mean, it's incredibly technical as a program that it's very, very hard to see it from a systems perspective. And so when I look at my career team, these are individuals who are 800 miles deep on a given subject, but often 2 inches wide. They are total mastery of their subject. And that's great because if you need an answer on a topic, they'll give it to you and they'll do it incredibly well and incredibly quickly. The challenge is you have this very large, complex system. And when you flip a light switch upstairs these days, sometimes the toilet flushes downstairs. And you're sitting and saying, well, I don't know why the toilet just flushed. I just turned on the bathroom light upstairs or in the bedroom light. What happened? And yet that happens a lot. And what's also happened, we were talking about this earlier this morning, is the covariant impact of a series of policy decisions that are being made often now supersedes and outweighs the explanatory power of the coefficients of the underlying variables that you were attempting to affect in the policy themselves. And so I've got somebody over here working on something in a Center for Medicare, perhaps in Mood Ring on drug pricing, and I've got somebody over here doing something with MA policy, and then there's somebody outside the Center for Medicare that's doing something over here, perhaps at the FDA, and maybe they're not totally talking and we're not looking at a systems perspective. And each one of those is a very thoughtful, careful, well-considered policy, but then when we put them together, we don't get the outcome that we want. And as much as we want to gripe about the healthcare system today, it is functioning exactly the way it was designed to function. We maybe just didn't realize it when we were designing it. And so we're trying to spend a lot of time right now thinking through how do we get different groups of stakeholders who, by the way, like each other but are oriented in a very hierarchical way to collaborate. And how do we get them to think about making decisions as a function of principles? And how do we get them to talk to the market and get that kind of real world feedback coming in for these policy ideas to understand what might be the negative public externalities or private externalities that we can't anticipate, because it turns out it's very difficult to anticipate every consequential action that will come from a major policy change. I mean, in the last week alone, the Center for Medicare has put out 5 major rule sets. It's many thousands of pages of new regulatory actions. Thousands and thousands of pages. And that's just in the last week, shifting hundreds of billions of dollars of healthcare spend. That's 1 week. So how do you contextualize that? How do you get that to work? How do you think about the private market overlay? How do you think about the public health implications of that? It's a complicated exercise. And so we're trying to shift the way that we think, the way that we make decisions into this process so that we make better decisions and then still ground ourselves in the humanity of it all. I got advice from Andy Slavitt, who is the former CMS administrator under President Obama.
He's been here too.
He's amazing. He's the loudest voice in my head persuading me to take this job. His commentary was very straightforward. He called one day and said, "Hey, I heard your name's getting tossed around Mar-a-Lago, and I'm calling to tell you you should say yes." And I said, "Well, I'm not so sure," and expressed a few concerns. And he said, "Yeah, none of that matters." He said 95% of this job is making decisions for the 170 million Americans who get their health care from the U.S. government. And we need competent, capable people who will steward that program and look out for them. And 5% of the job, it's going to be really political. But you'll learn how to navigate around that. And someday maybe you'll be asked to do something that you disagree with strongly, and that's the day you resign. But until then, you can sit and criticize all you want. You can sit and wait for the perfect window of opportunity. Or you could just get off the sidelines and go serve now and do the right thing. And that was very persuasive to me. And then he gave me, when I was coming in, this really helpful piece of advice and said, it's a pretty big program and it could get really easy to make decisions that are a little impersonal. And I would encourage you, even though you have this excellent office of the ombudsman that will help your beneficiaries, I'd encourage you to talk to your beneficiaries every week. And I took that to heart. And so I talk to and email with beneficiaries every single week.
And when he says beneficiaries, he means actual people on Medicare. You're
members
calling
of our 68 million people who get health care from us. And the way that this goes, by the way, is I'm not contacting them. They're usually contacting me. And it's usually because they've reached a point of desperation. They've called 1-800-Medicare. They've talked to their physician. They've talked to their health plan. They've gone to their SHIP. They've talked to their broker. They've maybe raised something with their attorney general. They've gone to Medicare.gov. And they can't get their problem solved. And in a moment of desperation, they're typing in who is the head of Medicare? And then they get my name and they look for a phone number and it's probably some fragment of an old cell phone or personal email address, and it comes in and it comes with a heartbreaking story. It's, I had a gentleman who, we don't, in original Medicare, we don't pay for dental services. In Medicare Advantage, we generally do. But we'll pay for dental services in original Medicare if you have a transplant. And there's a risk of infection. This gentleman had all of his teeth pulled, all of them. And he couldn't get their claim paid. And so he had depleted his bank account to pay the bill. And he couldn't get any help. So he had no money. And he couldn't get anybody to help him. And the system was failing him. So he found his way to me. And I'm sitting there reading this email. And I'm in tears. Because you feel this failure of a system that he's counting on to serve him. And so we set it in motion. And in that moment, based on that single human experience, $1.1 trillion of Medicare, or now $2.5 trillion of HHS, becomes extremely clear. You can wrap your mind around it. You know exactly what we do. Because it orients you back to your mission. It orients you back to the values that underpin that mission. And that becomes a clarifying framework. This is a great way to live life, by the way, and I would encourage you to do it. We have family values in the Klomp family. We write them down, and we iterate on them in family councils from time to time. And if we feel like we're deviating from those values, there's a corrective function. We can hold one another accountable. This doesn't just apply to organizations. It doesn't just apply to teams. Being intentional about the life that you want to live, about doing well by doing good, which you've all already made the commitment to do by being here and choosing to have a profession in this space, becomes clarifying. So if you'll take the time to be intentional about it, decisions that would otherwise seem very difficult or very complicated become very clear. And you don't even have to make decisions. You just build process and they process through, right? So when we think about this system right now, we know that we have to do two things because we have a core set of values. We have a statutory mandate as well. On the one hand, we have to serve our beneficiaries. We have to have them have a superior healthcare experience. They've paid into the system their whole lives. When they turn 65, they expect it to be there. They expect us to show up. They expect us to help them lead their best lives for the balance of their life. We also serve taxpayers. We have to be wise stewards. Healthcare cannot be the thing that bankrupts our country. It is already the number one cause of personal bankruptcy. It is cited as the leading cause in 2/3 of bankruptcy cases. It will be the reason that the United States moves to a place of default if we ever do, if we don't fix it, because it is so big and it is growing so quickly. And we have to be responsible for that. We are stewards of that. So we think about near-term stability for our beneficiaries and those who serve them. And we have to think about long-term, how do we make this work for our children and our grandchildren so that the program will actually be there? Because the worst outcome would be that people show up and there's no more. There's no more system, there's no more program, there's no more money to fund it. But if you have a set of values, and thankfully as a country, we do, and we set those values as a country, and we set those values for people like me to come into and for people like our career team to come into and honor and respect, then these decisions become much clearer. They can still be hard, but they become much clearer.
And there are always trade-offs. I love, the story about you calling patients. It's something I've known of you kind of in your past versions of your career, but also in this one. And I think it's just a gorgeous example of centering humanity, which is another of our kind of principles and part of our strategic priority here. That if you're not actually hearing real people, if you're just sitting in our ivory tower or your ivory tower, right, you lose touch. It is so easy to get driven by incentives that are not actually connected to the work that we do. So let me actually then move from that to your new role as you were director of Medicare, expanded now. I'm at your chief counselor, I'm actually going to get the title, chief counselor, right, for HHS. And this is National Public Health Week. And when we think about public health in the United States, we think about Medicare and Medicaid. We also think a lot about the CDC. Talk to me about the CDC in your new role. We are all anxiously awaiting a new director. I know that this is a big focus of yours. What can you share with us about how you're thinking about that?
So 6 weeks ago, Secretary Kennedy in the White House asked me to take a different role. I still oversee Medicare. I have an extraordinary team that's doing an extraordinary amount of heavy lifting to continue to steward that program. But I now have responsibility over all of the day-to-day operations of all of the Department of Health and Human Services. So this is all of our child agencies plus the department itself, so roughly just under 75,000 employees.
Just when he says, so it's CMS, FDA, NIH, CDC,
and many other agencies. And roughly, little over $2.5 trillion budget, and again, a large number of team members, through which roughly 20% of the economy now flows, and the mandate was, it turns out healthcare has figured more significantly into this administration than I think probably maybe people realized it might, and there is a growing focus on the role of healthcare in everyday Americans' lives and affordability and the quality of life that we lead and otherwise. And so my mandate was to come in and help Secretary Kennedy and others level up, just tighten our processes, do our best work as efficiently and effectively as we can. CDC does not currently have a director in place. It's had a series of acting directors. Right now, Jay Bhattacharya has been serving as acting, and now with delegated responsibility, he also leads the National Institutes for Health. And so very quickly, one of my highest priorities was to help find the right leadership team for Centers for Disease Control and Prevention, and then put those names forward to the president for his consideration and ultimate nomination and decision. And so I won't get into the specifics of where we are in this process, but I'll say what we are looking for. And what we're looking for is, let's focus on this for a second. Centers for Disease Control and Prevention. That P is really important. And if you think about the mission of CDC in particular, it really distills into two simple things. We want to prepare for in case something bad happens, a pandemic, for example. And we learned several things about our first big test drive in modern day through COVID, which was we weren't quite as prepared as we thought we might be. And then we want to prevent. And that prevention manifests in two different ways. Internationally, we want to be the tip of the spear. We want early detection. We want to help people all over the world be healthy so that we can also help Americans be healthy. And domestically, we want to work deep into the community because, as you know, public health is a battle that is not fought nationally. It's not fought at the state level. It is fought in homes and communities far in. But we have varying levels of preparedness. We have varying levels of capability. We have varying levels of resource at that level. So that's the complication. And so when we think about leadership for the CDC, it needs to have clear direction. It needs to have clear focus, not being distracted. It's full of exceptionally talented scientists and other individuals who are committed to this mission. But lots of organizations can have exceptionally talented people, but if you don't have clear focus and direction and leadership underpinned by values, you will row in different directions. You could have the winning boat, but you won't win because you're not rowing in perfect unison. This is boys in the boat.
Yeah.
And so we're looking for a team that is of unassailably high moral character, that will not compromise, that will honor the values of that organization, of our country. We're looking for individuals who have a focus and a dedicated history toward public health and service, toward preventive health, and toward infection control. And you could insert epidemiology and virology here from a specialty perspective. And then individuals who have administrative excellence, because this is a 12,000 person, extremely complicated organization that works multinationally and multilaterally with many other countries and many other organizations, and with many other municipalities and counties and states to undertake this incredibly complicated task that we desperately need to do the right thing and to be there when we need it. We just don't know when we'll need it. And so this is a top priority. It's a top priority for the president. It's a top priority for the secretary. It's been a top priority for our team. And I'm really excited by where I think we're going to potentially land.
We're lucky that you are helping to guide the search, Chris.
I don't know about that, but I'm excited for where we could go.
Oh, thank you. I'm going to ask just a couple more questions, then I'm going to open it up to the audience. There are two questions that I often end our Leaders in Public Health series with. One is about what we can do within academia to help the leaders who I have the privilege of sharing this stage with. And the other one is about our students, because we are ultimately an educational organization. We are here, I am dean rather than doing something else because I believe in our students, I believe in education, I believe in the ripple effect that is possible by training great folks to go off and lead in public health. And so I'm going to ask you about those two things. What can we do from within academia to help in your mission? And then the second one that I'll come to, so I'm giving you some time, is to think about what our students can do, especially in this time that feels quite chaotic, destabilizing, and dispiriting to many of them, how they can move forward and what they should be thinking about. So let me take that first one around what we in academia, those of us that are faculty or staff in the room, how we can approach this time. What sort of things you would love to see us doing that would be helpful?
So one obvious intersection point between academia and everything that we do at the Department of Health and Human Services is through NIH in particular. So if you think about how HHS was organized in the first place across the 4 core agencies, the idea was that NIH would research the challenges, the healthcare challenges that were most significantly facing Americans and try to come up with answers, right? One of those at the root of the MAHA agenda for the secretary is why? Why is it that we have such a high chronic disease prevalence that's making us so sick and frankly driving healthcare costs to an unsustainable level? We don't know. Is it the 10,000 plus emulsifiers, additives, and food dyes that are in our food supply that we've approved, by the way, through the FDA to be there? Is it environmental factor? Is it something else? We don't actually know. We just know that that rate has continued to climb and it has made us sick, but we don't know why. We don't exactly know what's going on with cancer in every instance. Turns out there's a lot of opportunity there. We don't still exactly know what's going on with dementia in its many different forms. There's an opportunity there. If you think about the biggest challenges, healthcare challenges that face us as a country in the aggregate, it's those three buckets. And we spend $40 or $50 billion as a country because we determined that was a wise use of resource, by the way, to invest in research generally performed through research scientists at academic institutions such as this to answer those questions. Along the way, I think we maybe chased a few shiny objects that were intellectually curious or interesting, but that strayed from the core objective. And what was the core objective? It was to answer questions that would alleviate human suffering. And so I hope that we will be able to refocus where we are spending our money, because it is not unlimited in nature, by the way. It's all borrowed. We know this, right, based on our deficit spending. So we need to spend it wisely. That we'll do it in partnership with all of you as expeditiously and efficiently as possible to answer the most pressing questions that cause human suffering so that we can then alleviate it. And then the FDA steps in, by the way, and then makes those things on the basis of safe and efficacious available to the market. CMS is the payer that figures out how to pay for them. And the CDC sits there prepared and ready to prevent in the event that something goes south. And that was the idea of the whole organization. And it works when it works well, and it's working together. My job is to help it work together more efficiently, more effectively. We can't actually do most of this, right? Our job in government is not to answer all those questions. It is not to solve all of the problems. It is to create an environment through policy and mechanism and funding to empower the most brilliant, beautiful minds sitting here to go answer those questions. And then with an accountability and stewardship, report back and make that knowledge available to humanity. And so I think we can continue to do a better job staying focused and working together in collaboration with that, again, core objective in mind. Not because something is intellectually interesting, but because it is pressing.
Sometimes we'll still do the stuff that's just intellectually interesting because that's what we do. And but you answered of how we can work together. And I love the focus on translation. As you all know, our first strategic priority is about making sure that our great research turns into real world outcomes.
And I don't think people know that. And we've got to do a better job of that. Think about that. We're spending $40 or $50 billion a year on research. And I don't think if you polled the average American, my guess is they couldn't tell you what NIH stands for or what it does or that it works with people like you. They couldn't tell you where the money went. And they definitely couldn't tell you, well, what did we get for it? What did we learn? What were the failures that we learned from? What were the successes that then resulted in groundbreaking cures or groundbreaking policy changes to help people live healthier lives?
And it's not just about marketing, it's about actually making it tangible, useful, usable.
Yes. And then educating so that people then maybe have a little more confidence in their government as well to say, it's being a wise steward. I'm grateful for that public institution. I have trust in that public institution. It did something that helped me live a better, healthier life. And that is the point. That's why it exists. And so we can do a better job. We together can and must and need to do a better job of this.
So now let me close with a question around our students. And I will say very honestly, last year we had a lot of students that thought they had jobs and then suddenly didn't, often in federal and state governments. We have students that range from 1-year master's students through 5-year PhD students. They have entered the field of public health because they are both methodologically curious. They want to learn how to do health economics or epidemiology or, name the thing, and because they care about service and making the world healthier. So what words of wisdom do you have for our incredible, incredible students as they face a future of public health that, as they look at it, it feels pretty murky and uncertain and destabilized?
Well, maybe I can clarify that uncertainty just a little bit, which is let's move beyond the past year. As Dr. Oz likes to say, you didn't realize it, but you came here today because I'm recruiting you, and this is a recruiting trip. We are growing, we are investing, we are hiring. We need people in political roles, in career roles, in fellowship roles. We need people in public health. We need beautiful minds of people who want to sign up for the higher moral calling, for this stewardship, to show up and to contribute in many different forms. And that can be in the local community, but it can absolutely be in our core agencies as well. We are actively hiring. We are in growth mode. We need you. We want you to apply. I can tell you, I've never done something in my life that is more fulfilling than this right now, getting to work with our career teams. They are exceptional. And the opportunity to come and learn from them and to be on the ground and to see what you're doing and how that translates into the relief of human suffering and advancing the nation is extraordinary. And there are so many opportunities. We want you to come. If you email, we will respond. We will talk to you. We want to educate you. We want to help you understand what the opportunity sets are. We want you to learn. If you choose not to come work here, we want you to still partner with us. We want you to be aligned with the things that we're trying to accomplish as a department and agency that will far outlast people like me as we come and go. Right? We want the public to have trust in these important institutions and to know that they are serving them to their best of their ability. That comes with you as well and helping build that trust and being on the team and contributing. So I hope that you will. I hope that you will consider that. I am not being hyperbolic when I say that it is an exceptionally rewarding opportunity to serve.
Oh, and anyone would be lucky to work for or with you, Chris. So
how about
it
that?
Is. And I will make sure.
That's my team.
Yeah, I know people on your team, and they think you're prior and you're current, and they all think you're awesome. So we will make sure for our students who are in the room or who are on Zoom that we get information. I know you have a fellows program. We'll make sure that we get information that we can share after. And I just have to say how much I appreciate. We were originally going to have a whole day of things. Chris has some new responsibilities in the last 6 weeks. So just the fact that he is here is an incredible testament to his commitment, both to the field of public health, but also to that true kind of recruitment potential and to what our students can and should do in the world. And so I will make sure to follow up with that stuff so that we can continue, knowing that you are going to have to disappear quickly after this conversation. We'll get that info and distribute it. I am now going to open it up to the room for questions. We'll go here and then Michaela, and then we'll do as many as we can. So.
First of all, thank you so much for being here. It's great to learn from your professional experience and connect with you as at a human level. My question to you, like during major Medicare reforms, like would increase the coverage or the efficiency, how did you elevate health reform into national agenda and as an investment case? And what strategies, because you talked about like personal level, how do you connect with people and patients, but as system level, like what strategies ensured communication or communities like were engaged as a co-owners of a reform rather than passive beneficiaries?
I love that. That's great.
And I hope you're making nomination, you're not taking our dean.
Well, actually, I said it was recruiting.
No, Yale has my heart.
I know this is true, actually. So a few different quick riff thoughts on that. First, from Reform Agenda and Medicare, I think by default, people understand that it's a $1.1 trillion program, but more importantly, Medicare is both the largest payer on the planet, it's the largest line item in the federal government's budget. It's also the most powerful regulatory rulemaking engine in the federal government. And where Medicare goes, so too does the rest of healthcare. So even if you're not interested in working in Medicare, you should be paying attention to it. Because when we set a rule, right, when we set a benchmark, when we set a policy, when we set a rate, that will directly, 80% of the time or more, affect commercial and Medicaid policy as well. So where we go, so too does the rest of the world. So we have the ability to move all of U.S. healthcare. So interestingly, when we are sitting and having discussions and we're thinking through policy considerations and we're moving that through the clearance process, we are not often just sitting and saying, well, this is what it's going to do for Medicare. We are talking about, well, what will this do to the country? What will this do to U.S. healthcare? And when we sit and talk about problems that we want to solve in U.S. healthcare, we're sitting and looking at the rulemaking engine and tool sets that we have in Medicare and in Medicaid and in the exchange and marketplace plans and with the Department of Labor through ERISA and the commercial plans, and how do we leverage all of those tools to change things forward. So for example, prior authorization. I think some of you probably know what that is. This is when your doctor says you need a CT scan for this unknown mass. We got to figure out if it's malignant or not. And then your insurer says, but hang on, we got to get that authorized before we'll pay for it. And then you wait. And then you wait some more. And you might wait some more.
And meanwhile, the doctor's fighting. And
that's right. They're fighting and spending tons of time. And normally you might be okay waiting just a little bit, except you're in this moment of peak uncertainty. And humans do great with certainty, good news, and they do great with certainty even in bad news. The one thing humans can't handle is uncertainty. We don't do well with it. And this is this moment of uncertainty. Do I have malignant cancer? Do I not? What is this thing? Da, 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 da. And this organization, someone there is telling me to wait. And my doctor I have a relationship with is telling me I need this thing and I can't get it. And it's this massive wedge that's driven in. And so we went after this. But we didn't want to just solve it in Medicare. Turns out it affects everyone. So we wanted to appropriately have prior authorization where it needs to be appropriate to control costs and maintain affordability, but we wanted to improve this patient and physician experience and maybe actually begin to repair a little bit of trust between providers and payers along the way so we can make some more progress on value-based care as a country. And so we leveraged our tools across many different things to drive that forward. The national rhetoric had already put that front and center, if nothing else with Brian Thompson's murder. Coming out of United. But then very quickly, we said, well, we got to do this. We got to fix this. This is a problem for everyone. Like, this is a place to alleviate suffering. So that actually tends to be very obvious on how we set priorities and how we set agenda items, broadly speaking. So it's not too hard to figure out where the problem sets are. What is hard is sometimes to figure out what our regulatory authorities are that will continue to allow us to do it. The other comment I would make, simply the second part of your question is, we know that we have to manage cost. And so when we set policies, we know that we have to do that, to your point, around trade-offs in a way that's responsible. And so we're interacting with all of the different stakeholders, and we're trying to send some pretty loud signals right now that health systems and health plans have got to start to wrestle with cost, because we're reaching a fever pitch of lack of affordability where families can't afford their premiums, they can't afford the deductibles, and the program actually has to be around. It's got to be there. It's got to be there when they need them. Right? You can't have 2/3 of bankruptcies citing medical debt with 1/3 of American families carrying medical debt on this thing that everybody needs in that moment when they most need it. And so that's where we're focused on Medicare. That's where the team is focused. I don't know if that covers your question or not.
Awesome.
Other parts.
Go to Michaela.
Sure. Thank you so much for the great talk. Michaela Dinan, I'm a cancer epidemiologist whose work has benefited from NIH funding, and I adamantly agree with the statement that you made that we need to do a better job of working together to demonstrate and to speak about the impact of our work. Often when we're thinking about impact, at least from the cancer epidemiology perspective, we're thinking about work that changes practice, informs policy, or shifts paradigms in terms of how the science itself is conducted. Are there other ways of thinking about or demonstrating impact of the work that we do that falls outside of those three?
I think it comes back a little bit actually to the Dean's question earlier about how we work together. I think that we often ship out a grant to you, and you've jumped through many, many different hurdles in order to qualify that grant. And then the tree falls and no one hears it. And it might find its way into a molecule. And then that might actually take a long time, so no one actually realizes it, right? Because right now it's about 15 years from concept to commercialization on a new therapeutic, which itself we have to change. That's a core objective. You've heard from Commissioner McCary. We want to go from 15 to 5 or less. And we have the technology now, we think, to largely be able to do that and still do it safely. Excuse me. Nevertheless, you come up with this brilliant insight, right? So there's this what, so what, now what framework, right? So you know the what, you figure it out. The so what, you understand why it's important. Now what, you're going to go push this off, and then eventually that's going to trickle in and begin to affect people's lives. But why aren't we giving progress reports along the way? Why aren't we showing the amazing breakthroughs that you're having? And we're translating that not into some academic medical journal where you're publishing your research, but we're actually translating that into plain speak English for families and giving them hope and saying, hey, this brilliant scientist at Yale conducted this groundbreaking research on something that affects X number of lives and causes untold suffering. And it turns out that the government decided that was a really important thing to address, that maybe the private market itself wasn't going to address, and that is the role of the government, is to do things where there's a private market failure. And so you did this, and this was a partnership, right, between the government and academic medical institution, or a government and a private institution. And look at this amazing thing that happened. And not that we're going to vilify because a pharmaceutical company or biotechnology company stepped in to actually commercialize it, because they needed to get a return on their capital as well, but to give hope to families and sit and say, this is the amazing thing that's happening. This is the world of creation. This is what we're doing to make life better tomorrow than today. But instead, we're largely silent on all of that. I come back to this. People don't know the work that you're doing.
Yeah.
They don't know the work that the government is doing. They don't know that we're working together. And I think if they did, they might have a little more hope. And there'd be more cause for optimism. And maybe in that process, we'd be a little less polarized. And we'd be a little more unified, and we'd work together a little bit more in other ways, using healthcare as that not only issue that could be unifying for everyone, but the catalyst, the first thing that was unifying, that built bridges and allowed us to do more and more together, irrespective of our ideological or political views. So that was probably a bigger answer than you were looking for, but I'm not exaggerating. I learned this principle actually when building your first company, which was I had this chief marketing officer, and she would beat into me over and over and over because we were just so focused on product. We had like no marketing engine, no marketing budget, nothing. We pushed everything into our clinical team and our product teams. And she kept kind of hammering us and saying, Chris, like the best product usually doesn't win. And I rejected that forever. And then I started to see competition that had clearly inferior products taking market share from us and at prices that were higher than ours, and feeling frustrated about that. And it's because they were running circles around us from a marketing product. It's the best marketed product that wins. Well, we have an opportunity here to have the best product that's also the best marketed product. And the marketing actually matters. People need to know. We need to communicate, make it clear, and we can do that better. If you have ideas on how we take what you're doing and it's groundbreaking, and we shout it from the rooftops and give people hope, because hope actually is essential, let's do that.
I didn't pay him to say any of that, by the way. I can't because he's a government employee, but also it's, yes.
Way to put that legal disclaimer on.
Unfortunately, I'm so sorry, you guys. I know we could go on for like 6 more hours because there are 1,000 topics that I know that I wanted to get to that we didn't, and I know that you all wanted to get to that you didn't, but you have to go and catch a plane. He literally has spent 4 hours 5 plus 3. You've spent 8 hours in Connecticut in order to be here with us this morning.
I wish I could
Chris,
spend
I am
more.
so grateful for your time, for your expertise, for your moral compass, for your leadership, and the country is lucky to have you serving. So thank you.
Thanks for having me. Thanks for being here. Appreciate it.